and I know that many of you have heard a talk from the binding site in the past. I have to tell you that Naveen Bangia gave the talk, and for the first time, I understood what the FreeLite test was all about. It was truly amazing. Not only did I understand it, everybody in the room understood it. So we were like, oh my God, this guy is fantastic. We have to have him back, and guess what? Here he is. So give him a big round of applause. This is a super important test.
I'm already mic'd. Yeah, you just got to turn. Yeah, can you hear me? No? Can you hear me now? Am I a Verizon commercial? Yeah. Okay. So thank you for the introduction. Thank you for inviting me, Susie. And with that introduction, well, I have a lot to live up to. But I also want to thank everybody here, the patients here, because this is actually a very important part of my job. I feel that being able to help explain the FreeLite test and how it impacts your disease and help you interpret what's going on with you is really important to me. So if at any time there's anything that's unclear, please stop me. Just yell it out. Don't even raise your hands. I'd much rather stop and clarify before we go any further. So I do work at the binding site, and my role there is educational. So I help keep physicians up to date on the latest lab tests to diagnose myeloma and to monitor, and as well as patients. So, oh, you've got one up here. Okay. There we go. Okay, so by way of overview, I'm going to talk about monoclonal gammopathies. There's going to be some big words. I'm going to try and explain them as well as I can. And if I don't, stop me and ask me again, because then I haven't done my job. So monoclonal gammopathies, one of which is multiple myeloma. We'll talk about what is it, when was it first discovered, where is it, and then how it's detected. So the symptoms and diagnosis, and some of this you've heard already, and some of this you live. All of this you actually live. So symptoms and diagnosis, the lab tests, and then the FreeLite test. So as I said, multiple myeloma is a monoclonal gammopathy. And so this big word just really, if you break it down, mono means single. So it's a single cell. Clone means cell. It's a gammopathy because that comes from the term of gamma globulin, which is what the immunoglobulins are called. And then pathy is a disease. So it's a single cell type producing one type of immunoglobulin. And I'll use these terms interchangeably. The gamma globulin, immunoglobulin, antibody, they're all about the same thing. They're all the same molecule that we're talking about. And so in terms of monoclonal gammopathies, here's a pie chart of all the monoclonal gammopathies seen at the Mayo Clinic. This is from 46,000 patients that they've seen from 1960 to 2012. And what you can see is that the largest fraction of these disorders are this MGUS, this monoclonal gammopathy of undetermined significance. And what this means, this is 57% of all these patients. And what this simply means is that there's too much of the particular protein in your blood. So that's the gamma globulin or the immunoglobulin. There's too much in the blood, but there's no other clinical symptoms. There's no problems with the kidneys. There's no problems with anemia. And so these patients are really just watched, not treated because there's no cancer there. The worry is that these patients with MGUS then do develop into real myeloma, and that's 18% of all patients in this class. There's amyloidosis and then smoldering myeloma, a little bit more progressed disease. So it's kind of between MGUS and myeloma is this smoldering myeloma.
Can I ask you to put the lavalier on your tie?
Sure. Would it look nicer?
Yeah.
Is it because it's what? Is it louder now? Better now? Okay. Yeah? Okay. All right. Thank you. All right. So, so I told you that myeloma is a monoclonal gammopathy, but it's called, so mono means single, and multiple myeloma means many. And I was always confused about that until I looked up the history of where the name came from. So multiple myeloma comes from, obviously, multiple meaning many, and myel comes from the Greek word mulos, which means marrow, and oma is what we put at the end of every tumor. I think that's a Latin derivation. So basically, it's many marrow tumors. And so if you think about the history, I looked up the history, the first reported case was Sarah Newberry, a 39-year-old woman. In 1844, she suffered for 4 years with back pain and multiple bone fractures for many years. And upon autopsy, they found that portions of her sternum had these red pulpy substances. And about 30 years later, Dr. von Rusitsky was the first one to use the term multiple myeloma, and where he found in an autopsy of a patient that there was 8 bone marrow tumors. And finally, 6 years later from that, Dr. Otto Koller, another physician, found, again, multiple bone marrow lesions or soft red substances in the bone marrow upon autopsy of a patient. So since then, we've learned a lot more about multiple myeloma. We know that it's a cancer of the plasma cells, which are part of the white blood cells. So in our circulation, this is just blood flow. Here's our red blood cells, and we have white blood cells. They're actually look purple here because of the dye that's used in the lab to stain them. Otherwise, they're really clear and colorless. So these white blood cells are the ones that are involved in infection, fighting off infections, as you heard. Red blood cells are for carrying oxygen. And so the circulation carries these cells throughout the body, and especially through the bone marrow. And so over here you can see the different types of white blood cells that we have in our bodies. There's a T cell, macrophage, and then the B cell. And these are all 3 of these have different functions in fighting off infection. The B cells are really what I'm going to focus on today because that's where myeloma is caused by. So the B cells can change into plasma cells, and those plasma cells release antibodies. And they're like antibody-producing factories. They just pump them out into the circulation so that they can fight infection. But the B cells like to hang out in the bone marrow. That seems to be their home. So before I go into myeloma, I want to just tell you a little bit about what B cells normally do, what plasma cells normally do. So B cells here, they have a little immunoglobulin molecule sticking out on their surface. And each B cell has a different immunoglobulin. And what that's doing is they're surveying our circulation and all over for a fit with a bacteria. And if a bacteria fits with that B cell's immunoglobulin, like this one, for example, actually in this case it's here, if a bacteria fits, that B cell gets all excited and says, oh ho, we got an infection, and let's make lots of antibodies to fight off that infection. So that B cell then becomes a plasma cell, and that same little immunoglobulin gets released by the plasma cells to fight off and released into the tissues and the circulation. So you get lots of replication and lots of antibody production to fight off the infection. So these plasma cells actually divide and make more and more of each other. Again, this is part of the normal fighting off of infection, and that kills off the bacteria. You can see the bacteria being covered by these antibodies, and that helps kill them off with other parts of the immune system. Once the infection is cleared, though, we need all those plasma cells to go away, and so they end up dying, and we stop producing more. But a few of the B cells hang around for a longer period of time, because if we get that same bacteria again, we don't have to go through all that B cell to plasma cell change. These plasma cells will then get activated right away and be able to fight off that infection very quickly. In the case of myeloma, we don't get that contraction phase of the immune response. We don't get the plasma cells dying off. The plasma cells actually forget to die. So you've got myeloma where you've got too many plasma cells, and you've got each myeloma cell, which is the clone, remember, makes and releases one type of antibody, or gamma globulin, into the circulation. And so that's why it's called, again, a monoclonal gammopathy. So what do these immunoglobulins look like? This is just a picture, a cartoon of 2 different plasma cells. This is their nucleus. And then here's the proteins that they're secreting. These are the intact immunoglobulins, composed of 2 chains that are black here that are called heavy chains. That's just because they're bigger than the other ones, which are the light chains. So you've got 2 heavy chains and 2 light chains, and together, all 4 of these fold up together and make one molecule. And that's called the antibody molecule or the immunoglobulin molecule. Now, in addition to secreting these guys, the full molecule, they actually release little byproducts, just the light chains alone. So these are called free because they're not bound to the heavy chains. So they're unbound light chains. And so the plasma cell can be either a kappa releasing in terms of the light chain, or the light chain can be a lambda-like light chain. So there's 2 different types of light chains that can be released, but each cell is only going to secrete one type, okay? And remember, we've got millions of these in our body that are ready to fight off each different type of infection, because there are so many different types of infection. So it would be nice if it was as simple as that. The immune system is actually a little more complicated in that I just showed you these black heavy chains with the green kappa and the pink lambda light chains. And so these are IgG kappa and IgG lambda. The letter after the immunoglobulin, so antibody here is the same as immunoglobulin. We usually abbreviate it as Ig. And so the immunoglobulin G is defined by the heavy chains. So these have the G heavy chains. And in our, that's to remind me to tell you that, which I already told you. So there are other types of antibodies that can be secreted by plasma cells, and those are, in this case, they're IgA. You can see they're purple. And they're, again, the same green kappa light chain or a lambda light chain. So they get paired off together. And so finally, we've got here an IgM kappa. So it's got a different color heavy chain just to show you that it's different than the other two. And so what would you call this? IgM lambda, excellent. Right. So the letter after the Ig tells you what type of heavy chain it is that's in that molecule. And that's how so then depending on each of you, it depends on what type of plasma cell it was that became a myeloma, and that's giving rise to that type of protein. So some people might be an IgG kappa, some people might be an IgA lambda, for example. Yes? So they're just two different types. There's no, oh yeah, I should rephrase. So the question was, what is the significance between kappa and lambda? In terms of the disease, in terms of how bad it gets, there's really no difference that we know of at the moment. So kappa and lambda are just two different types of light chains, and I don't think it affects how the disease progresses or how well it responds to treatment.
Treatment's the same.
Yes, treatment is actually the same.
Is there a higher percentage of kappa versus lambda?
I don't know the answer to that question. I will have to look it up. And if you give me your email address, I'll get back to you, but that's a good question. Okay, so there are different types of multiple myeloma, and they're defined, we classify them based on what those plasma cells are releasing. So there's intact immunoglobulin myeloma, which just by its name, it's releasing the intact molecule, all those those heavy and light chains folded together, as well as some free light chains. So 95% of these patients are also secreting free light chains. And there's light chain only myeloma, which is not secreting the intact molecule, it's only secreting the light chains. So that's about 15 to 20% of patients. And then there's non-secretory or oligosecretory myeloma. So these cells are secreting very little, if any, light chains. And that's a small fraction of the patients. So just to recap what we talked about. So multiple myeloma is cancer of blood in the blood and bone marrow, and it's a plasma cell clone, so sometimes it's called a plasma cell dyscrasia. And all of these myeloma cells in the bone marrow cause all this problem. You heard Beth Feynman talk about the garden and if it gets overcrowded, so thinking about the bone marrow as the garden, where your B cells are developing into plasma cells, then and the myeloma cells are crowding out that area. And so what it leads to, if you've got lots of secretion of these monoclonal proteins in the body, the bone marrow, and the circulation, so you get intact antibody or free light chains, that's the abbreviation. But in terms of bone marrow function, the other function of the bone marrow is where your red blood cells grow up to become mature red blood cells so they can carry oxygen. So if they're getting crowded out, then that's why you have the anemia. And the same thing, you get destruction of the bone, that's causing the pain, and you get suppression of the normal antibodies because your normal B cells are also growing up in there to become normal functioning B cells that are going to make antibodies eventually. So then you get susceptibility to infection because you've only got one type of B cell developing instead of many different types, which we need to fight off many different types of infections. Okay, so how do we detect multiple myeloma? So I told you about this history about the discovery of it, and part of this story goes back to 1848, where Sir Henry Bence-Jones looked at the urine in patients with myelitis osseum. I had to look this up. And it means softened bones. It was a disease of softened bones. And what he found was that if he heated up the urine to 56 degrees Celsius, now I'm a scientist by training, but I don't know why he would choose to heat up somebody's urine. But if you heat it up to 56 degrees Celsius, it would get cloudy and form a precipitate, and normal people's urine wouldn't. So, And he did, that was one of the earliest diagnostic markers for multiple myeloma, is a precipitate or a little cloudy in urine. And we'll come back to that in a minute because I'm sure many of you are still having your urine tested. So the signs and symptoms of multiple myeloma are really common to other diseases, which makes it really challenging to diagnose. And these are just a list of them and the different frequencies. So it looks like anemia is one of the most common things, but anemia can be caused by many other things. So trying to figure out that myeloma is the cause of all this is a real challenge. And so that challenge really starts with, in terms of testing, it starts with a blood draw, and then it takes it to the lab. And this poor guy, I hope most of you can read this. It's not as easy as this, is the point, right? I mean, it's not, myeloma is really challenging. It's not like you get an arrow through your head and you know what's going on. So in terms of testing, how does it work? The blood is taken, it's taken to the lab, and in this little box with these little blue dyes here, what's done is your blood is taken, and we're trying to look at the proteins in the blood, and the way to do that, we separate them out. And to separate them out, the way we separate them out is we put them on a slab of Jell-O. Imagine a little square slab of Jell-O with little slots in it. And in those little slots is put your serum, or your blood. And once that's done, you've got many different proteins in your blood. And so that's depicted by these different balls, the red, yellow, and green balls. And to separate them out, an electric current is applied across there. And different proteins have different charges on them. So we have, some proteins are very highly negatively charged, and some of them are very positively charged. So if you have an electric current that's going from negative to positive, the negatively charged proteins will be attracted over here. And the positively charged proteins will be attracted over here. And so what happens is we run this out over the course of 30 minutes to an hour in the lab, and the proteins get separated out. So the most negatively charged proteins come down here, and the most positively charged is here. And so when we do that in the lab, and then we apply a stain to that gel matrix, so this is a red stain that binds to protein. So we don't know what exactly each protein is here. We know that this one is one of the most abundant ones, albumin. But right here is the gamma region, the gamma globulin region. So these are just simply called, because when they first did this back in the 1800s, this was albumin, then they said, okay, we'll call this alpha, and then there's alpha 2, beta, and gamma, just by the Greek alphabet, because scientists are creative like that. So gamma globulin region, you can see, is very diffuse, so it's a little bit broad, and that's because each antibody in our serum, in our blood, is different. They're all slightly differently charged, and we've got millions of them in our blood. So they each move a little bit differently, but they're all in this general area, okay? And so here's another example. Now that they're just using a black dye. The more intense the blackness, that means there's more protein there. And so you can see this is a normal profile. What's happened here is, here's albumin, and what they did was you take the what you do is called densitometry. You say, how black is this band? And they take a tracing, and it's the area under this curve that tells you how much of that protein is there. So you can see in the gamma globulin region, you've got this broad band because it's from here to here, and it's not very, very black, so it's only this high. It's a little hump. In the case of a myeloma case, where you've got lots of one type of protein, well, you don't get this smear anymore. You get one distinct band and lots of it, so it's very, very black. And when you quantify it, you can see you get a big spike, and that's why it's called an M spike. And this serum protein electrophoresis and urine protein electrophoresis that's done has been done since the 1800s. I can't find the first time it was actually done. It's so long ago. But the FreeLite test that I'm going to talk about now that adds sensitivity and allows us to be more efficient in tracking myeloma was FDA approved in 2001. So in terms of detecting myeloma, remember these three different classes of myeloma. We had the light chain myeloma, the intact myeloma, and the non-secretory. If you were only detecting the intact immunoglobulin molecules, the doctor would miss 15 to 20% of patients, right? Because these guys would not be detected. But if you're detecting light chains, then you're able to detect this class, and even some of this class of patients. So you're really able to detect more patients earlier. So the FreeLite test, coming back to this picture, what is it actually detecting? You guys should all know this right now. hopefully it doesn't detect, what it detects is this little piece of the light chain that's normally bound up to the heavy chain. It's normally all closed up and it can't be seen when it's a whole molecule. So it does not detect that, it does detect this. Remember, those are the light chains that are free, not bound to the heavy chains. And so that's what the FreeLite test detects on both kappa and lambda. And it's different. Now, this is something that I think is very important because there's some confusion, and sometimes lab tests get mixed up. And so the free light chain is not the same as a total light chain test. Sometimes when you get test result back, just be careful that you're noticing. Remember, the free light chains are these guys, and that's really small quantities in our blood, milligrams per liter. Whereas total light chains, because there's lots of these molecules in our blood, the total light chains are on the order of grams per liter. And so there's a huge difference, and hopefully you'll be able to see that. If something changes in your blood report dramatically, it might be some kind of mix-up like this. So that's something to be careful for.
If it's a
Yeah.
site up there, how can they determine that it's there?
In this case?
Yes.
In this case, it's a different test, and so what they're detecting is a piece. Oh, sorry. Let me repeat the question. The question was, if it's so tight, then how can this test detect all these light chains? There's still if it's so tight this way, like heavy chain and light chain, then this part is still exposed to the outside, and so it's a different test measuring a different piece of the light chain. Does that make sense? So it's measuring out here, and as well as these guys. So because we all have plasma cells in our blood, remember they're important for fighting off infection, we have free light chains floating around in our blood. And so the levels in healthy individuals of kappa is between 3.3 and 19.4 milligrams per liter. And for lambda, it's 5.6 and 26.3 milligrams per liter. And the real advantage of the test is that when you get a ratio, so you've all, hopefully, many of you have seen these results where you get the amount of kappa, the amount of lambda, and you get a ratio. And so the ratio tells us, is it a clone? By dividing kappa by lambda, and this is the healthy individual range between 0.26 and 1.65, if there's a lot of kappa in the blood, then this ratio is going to be very high. And if there's a lot of lambda, because lambda is the denominator, then the ratio becomes super low. And so you can just see that here on a picture form, where here's the normal range on this number line between 0.26 and 1.65. And if it's very high in the hundreds or thousands, then that person has a kappa secreting clone. And if it's very low in the decimal, then it's a lambda secreting clone. So in terms of diagnosing myeloma, there's 3 criteria. There's monoclonal protein in either the serum or the urine, and now or an abnormal free light chain ratio. So if you're outside of that 0.26 to 1.65 range. The second criteria is greater than 10% plasma cells in the bone marrow. And third is this end organ damage. Are the organs damaged? And that's by this Crab mnemonic. So calcium elevation, that's telling us that there's problems with the bone breaking down. Renal insufficiency, so that's kidneys. Anemia is because it's a blood disorder. And again, bone lesions that are seen by imaging techniques. So again, MGUS patients, those are the ones that just had the blood problem, but no end organ damage. They just have this criteria. But if you've got the first 2, then you've got smoldering myeloma, so that has a higher chance to progress to real myeloma. But again, at the moment, these patients are largely just watched. And then third, if you get all 3 of those criteria, and you've got myeloma. So I wanted to go through a few examples of the light chain. Yes? The question was, what is a high number that's dangerous on lambda? And the answer is anything outside the normal range. So if the is 26.3. So if it's above 26.3, then that's something to watch out for. Okay? And in some cases, some labs actually, since you bring this up, report this in milligrams per deciliter. So then the normal range is actually 0.57 to 2.63 milligrams per deciliter. So you have to really be careful and watch the units. Different labs do it differently. I apologize, should have mentioned that. Okay, so I wanted to run through a few sample FreeLite results. For example, a person comes in who's complaining that they're very tired all the time. Here's the serum free light chain, the normal ranges, so you have them as a reference, because I'm going to ask you questions now, and the lambda. So if and the other laboratory tests, there's no monoclonal protein, so no M spike, right? We saw that on serum protein electrophoresis. If kappa is 15, lambda is 24, and the ratio is 0.7, I've got a color coding here. Low is blue, green is normal, and red is high. So what would you say for kappa? Yell it out. Normal. Very good. And for lambda? Normal. Excellent. Green. And the ratio? So it's likely not a monoclonal gammopathy. It's something else causing the fatigue, maybe an anemia or something else. Okay, another one. You've got a person coming in with back pain and fatigue, and they see a monoclonal protein on the serum protein electrophoresis. What do you say about the kappa result? Lambda? Normal. And so the ratio is high. Good. And you know what? So the comment, then the diagnosis would be likely multiple myeloma with a kappa secreting clone, right? Because the ratio is high. Okay, last one. Can you guess what this one's going to be? Next one. So lambda is right, and ratio is low. Good. And so they saw a very faint monoclonal protein on the serum protein electrophoresis. So the free light chain kind of helped in diagnosis of this one as a lambda secreting clone.
Does the ratio actually mean anything? Once you know one is higher, the other is low, then you have your answer. You need the ratio.
Yes. So the question was, do you really need the ratio? Because if you know one is high and the other is low, then you already know your answer, right? And the answer is, it's still important to look at the ratio because sometimes both kappa and lambda will be in the normal range. Both of them are in the normal range, but the ratio will be abnormal. So one might be at the upper limit of normal, and the other might be at the lower limit of normal, and then you get an abnormal ratio. So certainly still be watchful of all three numbers. Yeah?
What would that mean? If both kappa and lambda are in the normal range, the
Right.
ratio is not, what would it mean?
That means it's abnormal for free light chains. Then you'd have to combine that with the serum protein electrophoresis information and clinical symptoms. Remember, because it's always all three. You don't treat just on a lab test, so you really need all three. Yeah.
Is the M spike important in getting this information, or is it not related to getting that information?
So the M spike the question is the M spike related to getting this information, or is it unimportant? So it's important, but it's not really related. So if I understand you correctly, you really need to have both run. So to capture as many patients, to detect as many patients with myeloma as possible, you want to have a serum protein electrophoresis and a free light chain test run together, and you need to use both those pieces of information because sometimes the serum protein electrophoresis will miss, and so free light is really.
Is that true for ongoing treatment as well?
In terms of so is that true in terms of ongoing treatment as well, in terms of monitoring? Yes. Yeah, you really want to have all the information. Okay. Sorry to mess you up, Susie. I know all this.
For this kind of talk, I think it's good to ask the questions when the slide is up on the screen, so we're
Good.
just punting now. It's good.
Okay, good. All right, so actually this comes back to your question. So why use the free light test? So you can use it at diagnosis, and as I mentioned, together with serum protein electrophoresis, with free light, you can detect, in this study of 467 patients, they detected 100% of patients. And in the other case in amyloidosis, it's also very good. 96% of patients can be detected with this screen. Yeah, amyloidosis, so the question was, what is amyloidosis? Amyloidosis is another plasma cell disorder where the light chains that are being produced by the plasma cell, they actually precipitate. They kind of aggregate and form clumps, and then they get deposited in the kidney and cause kidney damage, or in the heart and cause heart damage. It's a much more rare disease than myeloma. Okay. So it can be used at diagnosis as well as to monitor response to treatment, and then potentially if it can tell you if the treatment is working well or not, and whether therapy might need to be adjusted. And then finally to monitor for relapse or regrowth of myeloma cells when in remission. Yes.
Can you have both multiple myeloma
and amyloidosis?
Yes. So the question was, can you have both myeloma and amyloidosis? The answer is yes. So there have been cases where people have had myeloma and then also later diagnosed with amyloid. So the gold standard for an amyloidosis test. So the question is, how can you tell if you have both? The serum protein test and the FreeLite test will tell you about the excess protein in the blood, right? And the amyloidosis test, the gold standard for amyloidosis is where they take a section of a kidney, if it's kidney damage they're worried about, okay? They take a biopsy and they do what's called a Congo red stain. And that Congo red will light up, it actually turns apple green under a certain fluorescent microscope, but that will bind to the amyloid deposits. So it's a Congo red stain that will tell you about amyloidosis for sure.
You can't get that from the urine test.
No. No. So you can also see light chains in the urine as well. Yeah, same thing in the heart. Actually, so they don't. So the question was, how about in the heart? If the amyloidosis is causing problems in the heart, the other way to do it, they can just do a fat pad biopsy for a Congo red stain. So just actually, I don't even know exactly where they take it from, but they'll just take. Sorry. There we go. Abdominal fat. Thanks, Debbie. Yes. Question.
Do you know the relative percentage of amyloidosis patients that are lambda versus kappa?
Do I know the relative proportion? I think it's more kappa than lambda, like 3/4 to 1/4, but I might be mistaken. I'll have to look that up and let you know for sure. Okay, any other questions? Okay, so I just wanted to take you through examples of monitoring. You probably have your lab reports and your numbers. So for example, this is a patient with IgG kappa, and what's plotted here on the y-axis is the amount of kappa, just the concentration of kappa. Here's just a picture of the myeloma cells, for example, and the kappa chains, the light chains that are being released. And this is over different treatment period times. They were monitored weekly, and you can see without treatment, the clone was growing. You saw more light chains. Thalidomide worked quite nicely for a while, but then it leveled off. Dexamethasone was very transient, came down and then back up. So that wasn't working, and then Velcade brought that patient right back down into this. This is the normal range here of light chains. So you can see how it can be used for monitoring therapy. And another example is, yep.
So the proteasome inhibitor is a targeted therapy, right? And it's not killing the good
So the question was, the proteasome inhibitor is a targeted therapy and not killing the good immune system. The answer is no. It will kill the normal plasma cells as well. Absolutely. So but it does kill plasma cells especially well, because plasma cells are those antibody-producing factories, and they really rely on proteasomes to get rid of the junk protein that they don't need. So if all this junk builds up when you inhibit the proteasome, those cells die. So yes, it kills off the regular immune cells as well. Yeah. Question in the back. Let me show you this next slide, and I think it'll help explain.
This goes back just a little bit away.
Oh. Okay. Yeah. Let's. I've only got okay. Let me just go through this. So the question was, how often should the FreeLite chain test be done? And so that depends on your physician and how often, what kind of treatment you're getting at the time. Here's an example of a patient. Free light chain kappa concentrations in the serum here on the y-axis. Here's the time in days, and here's a treatment going on. And in blue is the light chain monitoring, and in red is monitoring that monoclonal immunoglobulin or the M spike. Remember that serum protein electrophoresis where you saw the spike, and they quantified that area under the curve? Well, they plotted that out, and what you can see is that the light chains drop much faster. So you can see it. You can see a change in the course of the disease much faster with light chains than you can with the intact immunoglobulin. And just before I answer the next question, and the reason that is that the kappa and lambda light chains have a half-life of only hours. What that means, what does half-life mean? Here's the myeloma cells, here's the protein that's being produced. If you stop all new production of protein, let's say you kill off all these myeloma cells, how long does it take for that much light chain to become half of what it was? If this was 1,000, How long does it take to get to 500? That's what's called half-life. And so for half-life, for these molecules, it's on the order of hours. In the case of the intact immunoglobulin molecule, it takes weeks. So if you kill every myeloma cell, you may not see a change in the intact immunoglobulin for some time. So I don't have a perfect answer for how often should you run the FreeLite chain test. Potentially, you could run it every week, or you could do it, many physicians, I think, do it on every cycle, but that's really something to discuss with your physician. And you had another question?
The answer would be too complicated.
Okay, we can discuss it afterwards if you like. That's fine. And feel free to email or call me if you have other questions.
And how does it relate to the disease? If the kappa goes down, does that mean the disease has been arrested or what?
Yes, so I failed to make the most, so the question was, how does it relate to disease? If kappa goes down, does that mean the disease is halted? And so I failed to make the most important point of the talk, which is that this is a marker of the cells, the amount of cells that are there in each patient. So if you have 1,000 and you drop to 500, then your disease is dropped by half. So yes, it's a direct correlation. Now, it's different between different patients. If somebody has 1,000 on kappa and somebody else has 500, that doesn't mean that the person who has 1,000 is twice as sick. They could have the same number of cells, but their cells are just producing more of that kappa light chain. So it doesn't mean that the disease is worse. But for each patient, it means the amount that it changes is really a reflection of the amount of cancer cells there. Okay, so sometimes you might see, yes? You didn't miss that. So the question was, I didn't say anything about beta-2M. And I didn't say anything about beta-2M, but it is a marker of the amount of cancer as well. So beta-2M is, at diagnosis, it tells you about how many tumor cells are there, but it's not really a direct link. It's not quite, yeah, I'll leave it at that. So it's also another marker of tumor disease, absolutely. Did you want me to say more about it? I can't compare free light chains to beta-2M. Like there's no, we don't know how they correlate or not. Does that make sense? If that's okay, let's take this up afterwards. Yeah, let's certainly.
I'm thrilled that you've got so many questions because this is really, really good. He's got 10 more minutes. But he's here.
I can do it.
So
I'm not here all of tomorrow. I actually have to leave today. So if you have questions that come up now, catch me right after this talk. And if not, then I'll give you my card. You can email me, call me, anything you need. Okay? But definitely catch me right after the talk. So why did my FreeLite? Sometimes FreeLite values change all of a sudden, with no therapy, for example, no treatment. And so be careful about this. And I just want to warn you of what are some of the possible reasons. Normal biological variation. The free light chains can change 20 to 30% on a day-to-day basis. So just because we don't know what's going on with the myeloma cells. So that's just normal variability. So you want to look for differences of more than 50%, for example. So if you have 100, if it drops to 50, that's when you're looking good. I mean, if you drop to 80, that's good, but then wait for the next result and see if it keeps going down, for example. Okay, were your tests run on a different lab machine or sent to a different laboratory? You don't know where your blood goes, right? Your doctor usually doesn't even know. So it really takes a bit of digging. And if you're concerned, try and follow up with that. Talk to the physician staff, find out if the labs, if it went to a different lab, and then if it went to the same lab, find out if they've changed machines. Sometimes it causes a change in the results. And if any of that happens, then try and get the sample run on both labs, for example, so you can kind of know. All right. The last section I want to talk about is why do we need urine tests? Yes?
Quick question. When the lab is drawn, does it matter whether it's AM or PM, or should it be consistent?
To my knowledge, there's no difference. Again, 20 to 30% on a day. So the question was, when the lambda is drawn, does it matter if it's in the morning or the evening, or should it be consistent? I mean, ideally, I think it would be consistent because we don't actually know the variation on a morning and evening cycle. Nobody's actually done those studies. So, but on a day-to-day basis, it's 20 to 30% variation. So, So why did you get the urine test? So remember, our blood is filtered by our kidneys. And so what I'm going to take you through a little bit now is how these light chains are actually filtered by our kidney. So red here is the blood flow. Green is kappa light chains. They're pretty small. They're 25 kilodaltons. Don't worry about the kilodaltons. That's just the size measurement we use. So think of it as pounds if you want. So 25 pounds. And pink here is lambda, and they usually come together as dimers, and so that's why they're 50. They're double, right? There's two of them that usually pair together, so they're about 50 pounds. And then the intact immunoglobulin, remember, is 150 kilodaltons. Okay. So these three molecules, as well as all of our proteins, are getting filtered through our kidney here, and in this glomerulus, what happens is there's a filtration step. So anything less than 40 to 60 pounds, for example, is going to go through there. So the kappa will go right through here, and anything that goes through here eventually will end up in the urine, okay? But what we do is when kappa light chains go through, this is a healthy kidney, kappa light chains come through, they hit this, what's called a proximal tube, and they get reabsorbed by the body and broken down, and we reuse those proteins. We reuse the building blocks to those proteins. So nothing actually appears up in our urine, normally, healthy kidney. Now, if we've got too much kappa being produced, the capacity that we can reabsorb and break down is 10 to 30 grams per day. That's quite a lot. But if we've got a myeloma case where there's lots and lots of kappa being produced, it overwhelms this reabsorption capacity, and this kappa light chains will come straight through, and you'll see kappa in the urine. The other problem is if there's a damage to this glomerular filter. So if that filter is broken and no longer being a proper filter to only let the small molecules go through, it's now going to let kappa, lambda, and the whole molecule go through. And what you're going to see come through in the urine is all three of them. Kappa, because there's so much protein coming here, it's overwhelming this reabsorption capacity, and everything shows up in your urine, and this is why you get a urine test. To look for these proteins in your urine tells the physician that there's some kind of damage in the kidney. Okay? So to test for intact immunoglobulin and to test for kidney damage. So to summarize, we went over monoclonal gammopathies, just by the name that they're gamma globulin. Remember that these four terms are really synonymous. They mean the same thing. Gamma globulin, immunoglobulin, IG, it's abbreviated as antibody. Kind of confusing. I know scientists are not very fun. They're made by plasma cells to fight infections normally. Myeloma, you have too many of one plasma cell. We talked about the heavy and the light chains, and that they can be detected with that serum protein electrophoresis. Remember that M spike? And then in terms of the FreeLite test, it's a blood test for the free kappa and the free lambda. Those are the ones not bound to the heavy chains. It helps detect more myeloma and amyloidosis. We can use it in diagnosis and monitoring. It's widely used across the globe, actually. And then we talked a little bit about light chains that are reabsorbed by the kidney. That's the way our blood is normally filtered. We reabsorb some of that protein so it doesn't end up in the urine. But if we detect it in the urine, then that really indicates that there's some kidney damage. So with that, any other questions I'm happy to take. This is my email address. Feel free to contact me anytime if there's any questions, confusion about your results. And this is an online resource for those of you that are really adventurous. Wikilight.com is a textbook of knowledge on these things. So thank you.
I'm going to allow just a couple of questions because I want to make sure we try to stay on time as best as possible. So, all right, one question right here.
One of these used to be called Bence-Jones myeloma because of the doctor. Which one was that?
So Bence-Jones myeloma is really just light chain myeloma. It's the same as light chain myeloma.
Any other?
Because it's light chains being released in the urine.
Suppose you see a fluctuation, like in my case, I went from 18 to 32, 34, month by month, and then it went to 42, and then the following month it went down to 32. Now, the truth of the matter is I was developing 30 lesions at that same time. So how sensitive, I'm wondering, can the light chains be in terms of determining any kind of future progress?
So was it the ratio that you're talking about that was 18, 32, 42, down to 32?
No.
Just the amount.
Kappa.
Okay, so in your case, you've got something, the myeloma is secreting very little amount of light chains. And there are, remember I showed you those intact immunoglobulin myolomas?
I understand, but I'm saying the fact that it went up and then it went down while
Right.
lesions were being formed, what could what could
Absolutely. So, and that's a case that's a clear example. We have to take all the data together. So the imaging data that you're talking about when you saw the lesions, this is not a standalone test. It's not, just for that. We have to keep everything together. And in that case, I think it was 20% drop, 25% drop there. Yeah. Yeah. Mm-hmm.
Time following a stem cell transplant where your kappa and lambdas are kind of adjusting, the bone marrow is adjusting.
Absolutely.
That's common and normal.
Absolutely. Yeah,
Thank
so
you.
until the immune system reconstitutes, remember this is all, the normal reference range is for people with completely intact immune systems. And so in the case of a stem cell transplant, the whole immune system has been wiped out. So I think it takes some time for that immune system to come back to normal levels.
Let's assume your kappa and lambda light chains both rise, the values both rise to where both are out of the acceptable range. However, you're maintaining the ratio.
Right. So what that is what it means if both of them rise is it's not monoclonal, right? So that's the advantage of the ratio. It tells you that kappa and lambda are both going up, which means it's what we call polyclonal. That can happen during inflammation or infection, where you've got many, many plasma cells getting activated to produce more light chains to fight off that infection or whatever inflammation is going on.
Now, what's the indication of that as far as the disease?
Again, combine it with the other data, to the serum protein electrophoresis and imaging data as well. If nothing else is going on there, then I think it's really, you have to consider that there's some underlying infection, viral, bacterial, or just non-specific inflammation. Yeah.
All right, oddly enough, this gentleman here has a question.
With all the medications out there, thalidomide, Revlimid, et cetera, what do they do to these cells? What is it that they actually do?
That's a great question. So I'll give you a brief, which ones did you say? You want to know all of them? I spent 10 years of my life trying to study what one of them does. That's the one I studied. No, they all do very different things, actually. So the Velcade it's proteasomes. It targets proteasomes in cells and kills cancer cells that way. Revlimid seems to activate the immune system somehow to get your own immune system to kill your cancer cells, because Revlimid does not kill myeloma cells if you put them in a dish. Velcade will. You take out myeloma cells and put them in a dish in the lab, Velcade will kill them. It's toxic to cells. Revlimid does not. And so Revlimid is somehow activating our immune system. That's why you get that flare that that the physicians are trying to manage. So Revlimid will activate the immune system to try and to kill your own myeloma cells. That's a simplified version. There's many things going on with Revlimid, but that's, yeah.
All right, I'm a sucker for one last question. All right, hold on.
Hi. Okay, I have a question. Does oxygen therapy help at all? I've been reading some things about oxygen therapy and yeah.
So-
Aside from maintaining life in general.
Does oxygen therapy, I'm the lab guy that's talking about free light chains to diagnose, so I have no clue about oxygen therapy. To be honest, I really don't know.